Good morning. I'm student Dr. Michael Nitis, and today I'm going to talk about the case of Heidi and how we saved her life with our diagnosis. Heidi is a 32-year-old female who presents to our clinic today. She doesn't have a true chief complaints and states she is just here for a physical exam so she can obtain insurance at her new job. She hasn't seen a physician in 3 years, but reports that she does see an OB-GYN for an annual exam. She reports that she is in relatively good health. She runs 6 to 8 miles per week. She does state, however, that she gets short of breath sooner while she's jogging, and attributes this to getting old. She also reports a weird feeling in her toes, most notably after she runs, but not necessarily the only time she feels it. And she goes on to state that she has a dry cough, and it's been going on for an indeterminate amount of time. She states she's sexually active with a long-term partner, and she's on the birth control Nexplanon. She drinks 4 to 6 glasses of wine or cocktails per week, and states that she is a non-smoker. She goes a little bit further into her job details and states that the building that she works in now overlooks a river, and it was recently renovated, a building that was built in the 1800s. On physical exam, we are not told much. We're only told that she has a faint wheezing on her respiratory exam. Which brings us to our information deficits, of which we have a lot. First off, what does Heidi really want out of her visit today? She states she's only here for insurance purposes, but then she goes on to mention a few troubling symptoms that she's had. Her annual exam. Is it an annual gynecological exam, or does this include routine blood work and a physical exam? What does in generally good health mean to her? Does she not take medications because she can't afford them, or because she hasn't been diagnosed with anything? Is it because she doesn't believe previous diagnoses? Does she take supplements or any herbal medications or alternative medications? Her Nexplanon, I would like to know when it was implanted. And where does she run? Did she buy new shoes recently? This may help explain the weird feelings in her toes. How much does she spread out the 6 to 8 miles per week? For instance, is it 6 miles in a day? Is it 1 mile every day for 6 days? I would like to know a little bit more about this. Additionally, how long has she been running? And has there been any changes in the amount she runs for the time it takes to run? By this I mean, a few months ago, was she running 12 to 15 miles? Did these symptoms start before or after she began her new job? This will significantly influence our differential list. Does anyone else she know have similar symptoms? Is this some sort of toxin that was in her building, or is this something that is only affecting Heidi? Was there full or partial renovation at her new office? Again, is this something that's affecting co-workers or just Heidi? What line of work is she currently in? What was her previous line of work? Does she have extended exposure to certain toxins? And her family history and childhood illnesses could significantly help us in determining what is affecting Heidi right now. And finally, does she had any smoke exposure throughout her life? Were her parents heavy smokers? Did they smoke around her? Is her significant other a smoker? She says she's a non-smoker now, but that could still mean that she was a previous smoker. Which brings me to my differentials. I chose non-small cell lung cancer versus small cell lung cancer, as the latter is more strongly associated with the elderly and heavy smokers. Non-small cell lung cancer is the majority of lung cancers, and while it is still associated with smoking in men, the incidence is equal among non-smokers between men and women. Occupational asthma, which is a form of adult-onset asthma, was my next choice, and while it was a tempting diagnosis, I did not choose it as one of the information deficits was the duration of her symptoms. I opted for a more long-term duration than her new job, coupled with the fact that she hasn't seen a physician in 3 years. Amyloidosis was very tempting as well, however. It can cause a very wide range of symptoms and is associated with multiple myeloma and other B-cell malignancies, both of which she would have more troubling symptoms than she's presenting with. Additionally, 70% of patients have renal involvement and approximately 60% of patients have cardiomyopathy. Heidi does not mention signs of either system involvement, and so the odds of her having amyloidosis are smaller than my previous two differentials. Vitamin B12 deficiency can cause pernicious anemia, which could explain both her dyspnea and weird feelings in her toes, which I took to mean paresthesias. However, the only risk factor that Heidi resembles is chronic alcoholism, which we could only infer by assuming Heidi drinks far more than she's admitting to. A few more risk factors are chronic H2 antagonist use or an H. pylori infection, both of which contradict the incomplete history we are given, in that she doesn't take any medications and she doesn't complain of any GI symptoms. Common other symptoms would also include depression, sensory deficits, or gait ataxia. Finally, while asbestosis came to mind initially due to the office building she works in, the time it takes to develop asbestos-related pulmonary conditions is typically long-term, usually greater than 5 years. Crackles are also a more common respiratory exam finding than wheezing. Non-small cell lung cancer is defined as less than 3 centimeters. The pathophysiology has 3 subtypes. I chose adenocarcinoma, which makes up roughly 40% of this type of cancer. It occurs mainly in current or former smokers, but it is also the most common form of lung cancer in non-smokers. It is more common in women than men, and more likely to occur in young people. This is a cancer of the mucus-secreting cells and usually found on the outer parts of the lung. Next is squamous cell carcinomas, which make up 25 to 30% of this type of lung cancer. They are more strongly associated with a history of smoking, and they tend to be found near the central parts of the lungs, near the main bronchi. Finally are large cell carcinomas, which make up 10 to 15% of non-small cell lung cancers. They can appear in any part of the lung, and unfortunately, they are fast-growing and metastasize quickly, making them harder to treat. Some risk factors for the adenocarcinomas include active or previous tobacco use, tobacco smoke exposure, or mutations on the chromosome 6q. Mutations on this chromosome were shown to increase the likelihood of developing cancer significantly in never and light smokers, which we could potentially assume is Heidi. Common chief complaints are dyspnea, persistent cough, hemoptysis, thrombocytosis, and abnormal spirometry. Additional complaints, depending on the course of the disease, may include weight loss, fatigue, or clubbing of fingers. Clubbing is typically present after long-term hypoxia to the tissues. Thus, we will likely not find evidence of this in Heidi unless her disease has progressed considerably, and many of her symptoms are included in our information deficits. Heidi's ECOG performance scale is 1, and this indicates she is restricted in physically strenuous activity, but ambulatory and able to carry out work of a light or sedentary nature, such as light housework or office work. Her Karnofsky performance status score is 80%, and this is a tool for functional impairment and different treatment prognoses. It indicates she has normal activity with effort, and she may have some signs or symptoms of her disease. To further evaluate for these, I would like to order a chest x-ray, which would be indicated initially to identify the location of the tumor. A tissue sample will be required as well. Staging will be required for the cancer prior to treatment options being considered. Here's a brief overview of the staging for cancer. It's obtained via the TNMM staging criteria as follows, where T stands for the primary tumor, N is regional lymph node involvement, and M is distant metastasis. There are 7 main components used in the U.S. for complete staging: a CT scan of chest and upper abdomen, CBC with differential, chem panel including creatinine, electrolytes, and calcium, ALK-Phos, AST levels, pulmonary function tests, only indicated if surgical resection is indicated, and mediastinoscopy, only indicated if surgical resection is indicated as well. For treatment, stage 1, surgical resection is highly recommended. If she is in stage 1A, follow-up radiation therapy is an option, however, not necessarily required. If she is in stage 2A, however, follow-up chemotherapy is recommended. For stage 2, surgical resection plus follow-up chemotherapy, and stages 3 and 4, for tumors that can not be removed successfully via resection, chemotherapy coupled with high-dose radiation therapy is recommended. Resection may include the tumor and an entire lobectomy, depending on its advancement. As Heidi appears medically fit by our standards, we would likely recommend lobectomy. Video-assisted thoracic surgery, thoracoscopy, versus thoracotomy is recommended if this tumor is in an achievable location and the patient is able to tolerate the procedure. Nearby tumors are also removed and dissected to evaluate for metastasis. The prognosis for Heidi is pretty good, considering I believe she is in stage 1. 58% 5-year survival rate for stage 1, 35% for stage 2, 10% for stage 3, and 2% for stage 4. We want to inform Heidi of possible side effects of her treatment. As lobectomy is most likely going to occur, the possible side effects are infection, bleeding, and a tension pneumo, all of which could be handled by the surgical team in the hospital. Potential side effects from radiation therapy and or chemotherapy, depending on the advancement of her cancer, include but are not limited to anorexia, nausea, vomiting, diarrhea, hair loss, fatigue, paresthesias, anemia, and leukopenia. We want to ensure Heidi has the most support possible. This includes her family and friends, and even professional support groups or other patient-centered support groups. She'll likely have to adopt a new diet to aid in possible side effects, such as her nausea, vomiting, and diarrhea, as a bland diet would most likely help the most in this case. And if she has constipation, a diet high in fiber will also help with this. We can give her antiemetics and pain medication. And it's important to keep up any form of exercise as much as possible so she can avoid any excessive fatigue and depression. To consider her ethical concerns, we want to respect her autonomy and make sure Heidi is completely aware of all her treatment options, including their possible outcomes and side effects. It will ensure that she feels confident in choosing treatment options that will most benefit her. For justice, we want to treat Heidi with respect and dignity throughout the diagnostic and treatment course. Additionally, considering this is a preliminary exam for health insurance, we need to be concerned for Heidi's mental health regarding her diagnosis. Non-maleficence. We should still avoid treatment that have the highest risk-to-benefit ratio, as we have likely caught the disease process early in Heidi and can afford to circumvent more dangerous interventions at this point. Beneficence. We want to be aware of the diagnosis and prognosis that was given to Heidi and how it affects her. This is a time when respect for her autonomy is shown, while also helping her pick the best treatment option. I'd like to thank Ms. Fisher, Ms. Hefty, Mr. Schwartz, Dr. Town, and Dr. Trawick. Thank you for listening.